Good morning, everyone, and thank you for your kind attention. My name is David Sine. I'm the Regional Administrator at the Centers for Medicare and Medicaid Services, for which we'll probably have to dream up yet another name because we have a whole other line of business now to consider, and one that's consuming us quite a bit. And it's a pleasure to be here, and on behalf of the Secretary, on behalf of Herb Schultz, our HHS Regional Director, other people that I work with at HHS and other parts of the government, we can't thank you enough for the work that you're doing. It's really exciting and it's really energizing to come out and be able to meet with groups and find out what they're doing. And I saw John Matson when I came in, and I've seen him at some other events, and I had this thought that we shared that I talk about a lot of different things. So Tuesday was bundled payments this week, another bundled payments the next day. We did a stakeholder call with Arizona, which is my federally facilitated marketplace state, with stakeholders there about how we're working on setting up the marketplace, and also we're doing a lot of work there and with all the states renovating the eligibility systems so that people can seamlessly move from a port of entry at the marketplace, and then if there's a determination that they're Medicaid eligible, has to roll over into that system. We're working very hard on that, and people in California are making tremendous progress on that. But what I said was, these different things that we talk about and think about are starting to really bleed into each other. And like you planted these bushes when you moved into the house, and now years later you have kind of more of a hedge. And it's really true that the agenda that we have around health reform is fundamentally about one thing, and that's the thing that I really came to understand when Don Berwick came to CMS, which is that there is one thing that we could do today if we suspended creating new pharmaceuticals, if we suspended creating new devices, and any number of other discoveries that are being made, if we could just get the people that take care of people, the families, the nurses, the health educators, the physicians, all these folks to somehow coordinate around the person that they're caring for and talk to one another. And it's hard to do. 100 years ago, it wasn't that hard to get the coordination part. We didn't have the science part. Now, 100 years later, we've got the science, but we have so many people and it's so diffuse, it's very hard to do the coordination. So while all the things that we're working on are really, really important, and all somewhat connected, I see what you're doing as the underpinning of the whole enterprise. We're not going to accomplish modernization of our healthcare system, addressing the needs of priority populations, getting a handle on reducing the waste and unnecessary treatment that goes on, without the underpinning of the data and the sharing of data and the communication with the right provider at the right time for the right patient with the correct information that they need. And we're a long way away from that goal, but we're getting there, and I'm excited that when I come out and meet with people that are working on that, that becomes more and more apparent. A couple of fresh numbers that I was able to get this morning that are not verified and published, but ones that I'm still excited about. It looks like we're up to about 17,000 successful attestations in the state here, which is fantastic. And for those physicians that are doing electronic prescriptions for patients where that's appropriate, we're seeing 85% of those prescriptions being done electronically. That's a huge lift from a meeting I remember 3 or 4 years ago. Jonah Froelich put it together when he was at consulting before he came here to the state in San Francisco to talk about e-prescribing, and nobody was doing it then. For those providers who have successfully attested, they're telling us that they're meeting the core requirements for more than 90% of the patients that they're working with there, and we've got 230 of our hospitals having successfully attested. And for applicable patients, they're using computerized order entry for 85% of those patients, and 35% of the time they're making that connection to the registries. That's so important for the public health goals that also have a lot to do with what we're trying to accomplish. So I'm excited. I salute all of you, and I'm really proud to be able to work with a couple people up here today who are a big big part of that work here in California. Robert Cothran, who's the technical director at Cal Health eQuality, and Steve Nickel from the immunization group. He's the chief of the registration and assessment section there at the Department of Public Health, and they have some more words to share with you.
Well, hi, I'm Rib Cothran, and thank you, David. I was at dinner last night and sitting across the table from some folks, and they asked me what I was going to talk about today, and I said the PEN priorities, and they looked with this questioning look on their face. What in the world is that? So I am going to pretend to talk about the PEN priorities and use that as an excuse to talk about the cool stuff that's going on in California. For those that really do want to know, the PEN priorities are a set of priorities that ONC is handed down to states, all of the states, as the pieces of health information exchange that we're supposed to concentrate on and successfully be measured on. And they include e-prescribing, lab results delivery, care summary exchange, and public health reporting. And so we are working on all of those things, but that's really a couple of areas that are the broader, we need to move data around. And so I really want to talk a little bit more about what's going on in California to move data around. Because I have to pretend I'm talking about the PEN priorities, we'll start off with e-prescribing. If you look right now in California, I think we're at about 92% of providers have access to e-prescribing. We're way beyond the 80-20 rule there. ONC is pushing us to higher numbers. So clearly the problem isn't that providers don't have access to e-prescribing, but the problem is that they're not utilizing it. And so CHEC isn't moving e-prescribing forward. That's a program within CalOHI itself, is looking at educating and outreach to providers and pharmacists both to get them to actually use the tools that they have in place. But I think it's an important thing that a lot of times people talk about health information exchange and consider it a technology problem, and it's not. It's an uptake problem. It's a utilization problem. If we look at lab results, well, everybody's using a certified EHR now, and EHRs are certified to be able to accept structured lab results. So clearly that's not the problem. Well, yeah, it really is. Stage 1 meaningful use isn't about interoperability. It's about getting EHRs out there and maybe collecting some data. And so lab results is a really good example of a gap in dealing with meaningful use, in that the requirement is that you incorporate structured labs, full stop. No discussion about the standards you use, the mechanisms you use to make that happen, or anything else. So what is going on in California is an attempt to get consensus use of a set of standards that are available in technologies today. That's HIE Ready, and Dr. Kaiser talked a little bit about that yesterday, and we've got some information here on HIE Ready if you want to understand that. We're also funding a great deal of expansion of regional exchange within California, because it is the HIOs out there that are actually building the pipes between labs and the providers that need to get those results. And during the course of this year, we're going to be funding conversion of labs to LOINC encoding. A lot of the high volume labs don't use LOINC encoding yet, and that's to prepare for stage 2, where we're really starting at least to think about interoperability. So there's a lot of money that we've been pushing out to regional programs that I think is really important. Raina, Becca, Patty, and Raina's team have been really instrumental in getting a lot of that out, along with all of the HIOs in the room here. So you know, there's a lot of congratulations that need to go out to those folks. Care summary exchange is about the movement of a document, but that's not really what the problem is there either. What is the problem is that we need to break down the stovepipes we're creating between EHRs and even the regional HIOs now, where they can move data around, but in transitions of care, you need to move around more information and across boundary lines. So there's an awful lot that we're doing there. It starts with the discussion that you just heard on KHI. I'm going to practice that. Where we need to establish trust between those organizations. That isn't a technology. That's a feeling that these folks are doing the right business practices, and therefore I should be able to exchange information with them. And setting up a technical infrastructure that enables that. So we also heard yesterday a little bit about the National Association for Trusted Exchange, or NATE, formerly known as the Western States Consortium. I always used to say that was the coolest thing I was doing. And it still is the coolest thing that we're doing. It's all about breaking down the stovepipes between states and making sure that we can move information across state lines. And so there's a great deal that's been going on there. NATE stood up the first trust community in the country back in November, has declared that that is no longer a pilot, and we are actually exchanging information for real now, not just as a test of what's going on. And IPHI and the Czech program continues to publish the trust bundle that is now a national standard for how you establish trust between organizations. Now the coolest thing that I'm doing is KHI, where we're applying some of those same principles inside California, because California also has stovepipes around its community and enterprise organizations, and as you just heard, information needs to move there as well. So there's a lot that we're doing around trust communities. Dr. Kaiser talked about that a little bit. There are standards for that. And the step beyond that is not just do you need to know that information is secure when it moves, you need to know who you're talking to. So that's about provider directories. So also the Western States Consortium last month stood up a federated provider directory implementation that was developed here in California, and both trust communities and provider directories will be part of pilot here in California, hopefully starting in July, based on some of the work that's going on in KHI. So now I have at least two things that are the coolest things that I'm working on. Just a few shout outs there too. I'd like to say thanks to all of the states that are part of NATE. Only one of them's here in the room, and that's the folks in California. But Cassie and her team and Aaron Seib have been very instrumental in working with me to move that forward. And then the provider directory work itself got kicked off with the help of Robert Lutoff, and the two guys down in the trenches are Santosh and Anshuman that have really been making all of that work. And like I said, that is up and running now. Very exciting part of that is that Stage 3 meaningful use certification will probably include provider directories based on what we're doing here in California. If people saw the S&I framework announcement about the modular specifications work, that's what that is. That is the California model, and I really encourage people to participate in their public call next week. And the trust bundle work is being tested on the national level. Literally today, if I weren't here, I'd be participating in that through a Connect-a-thon all across the country, where they're looking at the national standard for trust bundles that we got started in November. I don't see Will in the room because Will's probably out doing that right now. So he thinks it's the coolest thing that's going on too, clearly. And then public health reporting. So the problem there is not that EHRs can't report the information, but it needs to get someplace. Just like with labs, part of the problem is that the labs can't necessarily send out the right information. Is public health really prepared to accept the volume of information that hopefully is going to start coming in? One of the very cool projects we've been working on has been the immunization gateway. I'm not going to talk about that anymore. Steve's going to hit me. I have to leave something.
Everybody else has talked about it, so now it's my chance.
Yeah. So I won't. But I will at least mention that that's been a real great collaboration across a number of organizations. Chris Kim on my team has done a great deal to push that forward. The folks at CARE and the folks at CDPH and an excellent vendor at STC has really come a long ways on a very short timeline. So it's going to be, that's very exciting. And then Dr. Kaiser yesterday talked a little bit about Inspire, and that's going to be starting to take a look at the future. So what more can we do about public health? And that's still a growing idea. So a couple of people have come up to talk to me. I want to know more about that. Please, more of you do that, because what we're really looking for is a way that we can get clinicians and public health and patients all together and figure out, so how do we manage data, especially about high impact conditions, so that everybody gets what they need and can move things forward. And so it should better enable public health. It should be a good tool for clinicians, and it should give patients access to their data as well, surrounding episodes that are really important to the patients. So that will soon become the coolest thing that I'm working on. Chris Kim will be working on that with me as well, and we're looking for a lot of partners there. So I'll shut up now and let Steve talk a little bit.
Okay, I'm Steve Nickel with the California Immunization Registry. I'm the section chief. Could you click up my... So that's me. I'm going to focus now on immunization reporting because that's all we do. We're not concerned with other public health reporting. We really only care about immunization reporting. There are some specific challenges in California because of the way we're set up. This is a good example of what the problem is. We have 10 registries in the state. They don't talk to one another at all. Imperial County is actually, I'll include it in the group, they're sort of a honorary member of the group. They don't receive funding from CDPH. These are the, it's a little simpler than 10 full-blown registries. We actually have CARE is the umbrella organization that covers 9 of these registries. These are all funded by federal funds, and I will say that there's no state money for immunization activities in the state. It was pulled 2 years ago, so we're completely running on federal funds. That's part of the challenge. Most of the state is using a single software solution, but there are 7 regions using that software solution. So these are all managed by CDPH staff, so I'll be talking mostly about the CARE 7 challenges and solutions. One of the challenges is for meaningful use reporting is that we have essentially a fragmented system. We don't only have a fragmented set of registries, we have a fragmented reporting system. So this is from the CDPH website, and it's not a simple link to CARE. Obviously, if you're in LHDs that have registries, and those would be Imperial, San Joaquin, and San Diego counties, you report directly to your county, effectively, the registry in your county. If you're not in those counties, which is everybody else, you've got to go to the website, you've got to look and see what region you're in. If you happen to be in the San Joaquin region, you report to them, but if you're in the rest of the state, you essentially report to a single entity, which is the CDPH CARE 7. So for meaningful use, that's a challenge, is that there's not a single point of entry for reporting. This just summarizes sort of the stages of reporting. The first 2 stages are fairly simple, particularly stage 1. They submit a test, and if it's successful, there's assumed to be follow-up submission to qualify. The standards are HL7 2.3.1 and 2.5.1. These are usually VXU unsolicited messages with a CVX code set for vaccines. In stage 2, the assumption is ongoing submission. No more testing. You have to be submitting ongoing messages to the registry. It's going to then constrict to 2.5.1. Again, VXUs. With a CVX code set, but in stage 3 it becomes much more complicated. That's where part of the challenge is. The expectation is bidirectional, real-time query response. One of the issues, go back. So the issues, as I see them, the challenges, the current challenges for meaningful use reporting are regional variance. That's always an issue. That's probably always going to be around because there are counties that are running their own registries that have their own process. So that's probably something we can't do too much about. Issue number 2 is something we can do something about. CARE 7 software, currently the legacy software that we're using that we're going to replace, cannot speak HL7. So we cannot import HL7 messages, so we have to have a solution for that, and I'll talk in a little bit about the solution. The third issue is we don't have a lot of staff to manage this process. And we have lots of immunizing organizations. I just heard David say 17,000 people got credit for meaningful use. The number I think is most relevant for us in terms of immunization is that H1N1 vaccine recipients, those are actual separate sites. So we have almost 10,000 sites that receive H1N1 vaccine. So presumably that's our universe of vaccinating sites. So from the standpoint of receiving information, there's as many as 10,000 sites out there that will submit information to CARE. So what are our solutions? So this is an interim solution. We've actually procured a piece of software from Nathan Bunker, who's a well-known HL7 expert in the immunization field. We've essentially installed that software in CARE, and what it does is it translates HL7 into our native flat file format, and so we can import that information. It's a secure FTP process. Obviously, it won't be scaled up to thousands of submitters. It was piloted early in 2012, and we went live in July 2012. And basically, the whole state, I think it's the next slide, but the whole state in July of 2012 went live for meaningful use. Every region could accept HL7 messages. It's really only a short-term solution because we only support inbound messages. We can't do query and responses. So this is what I just said, is basically prior to July 2012, the only region that could accept HL7 really was CARE San Diego Immunization Registry. Now everybody can. So I just wanted to sort of give some credit to our data exchange staff and also the other regions. This is sort of our current status in terms of attestations and exemptions. Obviously, the rules for submission of immunization message allow an exemption if the registry doesn't have the capacity to receive them. And prior to 2012, July of 2012, we clearly didn't have the capacity to receive. So that's where some of those exemptions are. But basically, these are just the totals. We've attested between July 2012 and now, we've attested about 1,300 different sites. We've exempted about 278 statewide, and we have ongoing submission for almost 780 sites. A lot of these are Walgreens, of all places, that has about 650 sites submitting messages. So this is sort of our ongoing process with the HL7 jump. It's taken a lot of effort for our two data exchange staff, who had to hand manage all of these attestations. And obviously we need a solution if we're going to ramp this up to 10,000 submitters, potentially. So herein lies the solution. The solution is essentially this messaging portal. We're calling it the portal now. We're not calling it the gateway. The last slide will sort of indicate why we're not calling it the gateway. But this was funded by CHEC. Our friends in CHEC have come to our rescue through Health and Human Services, the cooperative agreement. Basically, it expands our capacity by letting all the people that want to do meaningful use in those 7 regions actually go through a streamlined process. So it's a website that enrolls you. It automatically sends you credentials to the appropriate contact. It allows you, subsequent to assembling your credentials and incorporating them into your messages, to upload messages. It's using the NIST tool, the National Institute for Standards and Technology. It's a site that ONC put up that essentially has an engine that will sort of look at HL7 messages and essentially give you diagnostics. So that's been incorporated into the site. The other thing about it is, as it tests messages, there's an automatic email that goes back to the submitter telling them it either has 0 errors and passed, or it has errors, and these are the errors you must fix. The message broker in the system that's incorporated in the system is Mirth Connect. And that's very important because, again, we have 7 registries currently that these production messages must eventually get to, so we need something to manage those messages, both test messages and production message. The other thing we've chosen to incorporate is SOAP transport. Everybody's talking about direct, but the immunization community has come down very strongly behind SOAP transport as the preferred method of immunization transport. CDC, every quarterly report asks us, have you implemented SOAP yet? And we have to say no, but obviously we say we're in progress. The other part of this portal is a management capability. Obviously, we have 2 people that are going to manage testing and production for all these providers. So we have a really nice management portal that allows them to sort of look at messages, look at the current status, change status, those kinds of things. So it's a really nice tool. It's not ready yet, as we've heard. It's very close. Part of the impetus for getting it ready was this meeting. We missed, obviously, but it's very close. I think we're going to be deploying to production very soon. We'll have a short pilot phase. We've already selected our pilot sites to actually go through the whole process, enroll, submit messages, et cetera. And we're hoping to go live in early June. At this point, I want to say thank you to everybody who's been involved in this project. I'll start with Czech, Chris Kim. Probably a lot of you don't know, he used to be the care manager, so he knows immunizations inside and out. So he was a great person to have to move this whole portal project forward. Obviously, the team at his Czech team. STC has been a great collaborator in this process. Chris also, I should say, Chris did the procurement. He wrote the RFP. He actually hired, he got the contract done. We had to do nothing virtually. CDPH had to do very little in this process. So thank you, Chris. Thank you, RIM. CDPH, our shout out to Ron Robinette, particularly Tom Lucero, who's really worked very closely with the vendor to make sure all these things were sort of installed in the CDPH environment. So, and of course, from Mike Powell on down, Mike Powell is our care manager. Everybody below him is part of our team, our care technical team, that many of those people were responsible for the HL7 jump installation. Do you guys want to stand up? Just everybody right there in that table. Stand up, all you guys. So this is our care team. So the long-term solution, obviously in stage 3, we need bidirectional. So this HL7 jump, which is basically just a place where we submit messages, they go one way. They go into the system. We need a secondary solution. So the secondary solution, which is really sort of the primary solution we've been working on for years, is to basically consolidate all the data in these 7 registries into a single registry, install new software that speaks HL7 and can manage real-time transactions. And because we do have independent registries, obviously our intent is to communicate with them. So if everybody's speaking HL7, I think there's obviously we're going to communicate with the outside world, so to speak, the independent registries via HL7. This won't happen until 2015. I think the timeline is fairly close for stage 3. So we're hoping that all the approvals go smoothly so that we can get this installed before 2016 when stage 3 happens. Now, the reason I didn't want to call this the gateway is because it turns out that CDPH wants to use major elements of our portal that was sort of designed as an immunization portal to basically as a way to get other types of public health reporting through the gateway. And basically we're calling it now the CDPH gateway. So the message broker will essentially decide where the messages go based on what kind of messages they are. The registration component will be preserved for any outside entity trying to send information to CDPH. And some of the different components down there, the recipients of this information, are like CalReady. Eureka is the cancer registry. Rascal is the childhood lead registry. So we're really taking advantage of this CHECK project to really create a public health gateway. Our part of it is the immunization portal, but it's really going to be a public health gateway. So that's the good news.
Well, we have a few minutes left. I know lunch is waiting and people probably want to get there, but we have a nice opportunity to take a couple minutes if we have a few questions anywhere in the audience. Let's see. Yes, ma'am.
I think you can hear me. So, Andy Patterson with the clinics and health centers. What's the plan for marketing and messaging to everybody about this great June rollout?
I had a slide in there, but I thought since this was sort of a extemporaneous sort of situation, I didn't want to have too many slides. So we've already put up sort of a tease on our website, which is careweb.org, that says coming, blah, 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 and has a page that describes the tool. I'm hoping that we can obviously we need to put this on the eHealth site, which is devoted to immunization reporting. I think the Cal-OHI site would be a good place for this information as well. We also have several listservs that we run from the immunization branch. We have a Vaccines for Children listserv. We have a CARE listserv. We have an EasyIZ, which is sort of our immunization training site. Health professional newsletters, HIE newsletters. Anybody who wants, please contact me if you have a newsletter coming up and we can sort of promote this on those newsletters. So, I think we have a game. We'll also put it on the logins for CARE. We actually do some messaging at the login. When people actually come in to use the application, we can put links and things like, immunization report now at the, go to the immunization messaging portal. Oops. Okay. Sorry. So I think we have a reasonable plan for getting the word out.
Hi, Jess Montoya, Riverside, San Bernardino Indian Health System. One of the slides for the immunization talked about credentialing. What exactly does that mean? Because as a FQHC and as a clinic system, we credential our doctors. When we went through meaningful use, we have to go through a process as well. But what does credentialing mean?
Well, am I on? Okay. Credentialing is, we used to have a string of text that said care ID, password, username, things like that, but we changed that credentials. So basically we're sort of auto signing them up. There's actually an access and confidentiality agreement as part of this. So they actually have to buy into the care usage agreement as part of this process. Once they've done that, they essentially get this automated care ID. There's some SOAP information they need for the transport. So those are the credentials. There's also a requirement for a CDBH client that needs to be sort of installed on their computer. So there are some security elements to this as well, but that's a sort of secondary to the credentials.
Jared Rutledge, Fresno County Department of Public Health. As an epidemiologist, I was most interested in the CDPH gateway, and I noticed that there was an HIE component. Would that be specific for the HIE regional and for the access for the local county health department so that we could have?
Our intent all along, even with Care One, has been to give counties access. It's just that we have two programmers. And basically, we've had a lot of VFC requirements recently that we've had to sort of incorporate into the Care One. But Mike and I have talked about this a million times. We need county access to the back end so you can actually access the data in Care. for whatever epidemiologic purposes you need. You know, cases, vaccine-preventable disease cases that you want to look up their records. So that's on the list. That's also part of the business requirements for CARE 2.0. So the new software will have the capacity for counties to come in through an admin portal to actually get information out of the database.
The e-records, 2 questions. So even though I'm sure it will work perfectly, how long can we use the current ways of doing the immunization? That's the first question. Second question is there any update on the syndromic surveillance component of the public health meeting?
I'll speak to the immunization. We do have a lot of people exchanging data. They won't be grandfathered in. They'll have to come back through the front and register at the gateway, because we now have a SOAP transport method. Previously it was secure FTP, so that's going away. So now everything's going to be SOAP. So everybody's going to have to conform their messages to SOAP. Well, obviously we're going to communicate with those current ones and sort of inform them. We have email lists for them, so we'll send them a specific email that says, oh, by the way, we're going to transform the process. You're going to have to exchange data via SOAP from now on. Go to the portal, sign up, get your credentials.
Hi, Lynette Scott, Department of Healthcare Services. This is more of a comment for all of us around language. We've talked about that several times over the last couple days. The question about credentialing, I just wanted to speak to, and one of the things that I've noticed in this presentation, and this is not a critique, there's been quite a few technical terms, and so as a clinician, credentialing is a very different process. For clinical folks, credentialing means, you know, I'm licensed, that means I have a license I can practice, but I can't actually work in a facility until I've been credentialed. And that facility then says, yes, you're not only licensed, but I agree, I will let you practice medicine in my facility. So when we talk about credentialing in a technical term, in terms of IT systems connecting, credentialing means you actually get a certificate that says, yes, you're okay, you can talk to me. And when we talk about credentialing in the clinical world, it means, yes, you're licensed, and I want you to practice medicine here. So it's an interesting sort of highlight, both in terms of the question answer in that language connection between our two worlds, and it's sort of a beautiful example of what we're doing here at the summit in terms of making those connections. So thank you.
Thank you, Lynette.
Yeah, and I think that is a good point. It came up yesterday about the language that we use, and one of the, you know, I think as health information exchange and health IT matures a little bit in the community, it is important for us to be precise about a lot of the things that we're talking about, and that's what creates a lot of these terms, and so we are going to run into conflicts, but I think that, you know, I have to agree with Lynette that part of the reason for summits like this is so that we understand what some of the things are that we're talking about. When we talk about trust communities, what is it that we're talking about there? Because that has a very specific meaning. When we talk about credentialing in the IT world, it has a very specific meaning. When we talk about it in the medical practice world, it has a very specific meaning, and that makes those terms important, but it is we all need to understand them even when we come from different backgrounds, and that makes this all difficult.
Ready for lunch?
I think they are.
It obviously appears that you did a great job. Thank you. Thank you so much.
Thank you.